I'm going to try and do like a bit of a share screen. And I wanted to try and be interactive because we're quite a small group, so we don't want to just hear me talking on. So I'm going to be asking lots of questions. We're going to be trying to cover just some emergency situations, diagnostics, things that we would be encountering. Hopefully to try and help you guys in two things really. One, when you have challenging situations and exams, but most importantly when you're in kind of real life and you're encountering these really sick children who are coming in huge numbers. So let me just start sharing. Can everybody see a little PowerPoint there with common emergencies in pediatrics? Can you guys see that?
Yes.
Yeah, fantastic. Let me try to get this thing sharing as a slide. Just having a little argument with my computer. 2 seconds. Where is this? Maybe this might do it. Great. Excellent. Okay, fantastic. So just to introduce things really, first thing to understand is we really pediatrics, there's about 5 or 6 emergencies that you will encounter, and most commonly children fall into those situations. And I just want to talk through some of those situations using examples really, rather than just me talking. I want us to try and all sort of interact and offer thoughts and perspectives. So a couple of thoughts. I mean, being prepared is essential. So very interesting hearing you say at the start there, Dr. Kaminer, about the issue with the epinephrine. That is a challenge the hospital is facing, in that there is a constraint around our being prepared if we don't have epinephrine. So it's good that you highlighted that, because we can look at making sure that that is ready. Similarly, if you have a situation, child comes and not breathing and everyone's running around looking for the ambu bag, they're looking for the diazepam, they're looking for the, whether it's Keftrax or whatever, everyone's just running around looking for things, it can mean there is a long delay. So that's why being prepared is very, very good. So I think one of the action points from today is we'll try to put together a stronger emergencies medicines kind of thing on the ward and in the ER. And I think I would say as well, team working is really important. You'll meet some of the PAs and some of the nurses have a lot of knowledge, some of them have less knowledge, but sometimes they'll tell you things or they'll help you with things. And if you're all working together as a team, you'll find that they can really move you in the right direction, because we're all human beings. There's no way that if you have a child who's not breathing that you can manage that on your own. So I encourage you to bring in as many people as you can. So I want to do the first example. What we're going to do, I'm just going to read through this, and then we're going to have just a few questions and thoughts about what could be the problem. So I've got a 2-month-old baby with a 2-day history of vomiting after feeding. And the mum is saying that the vomiting is usually like food and breast milk. So usually milk or breast milk. And then after the vomiting, the baby is always still hungry, trying to suck. But the baby is just losing weight for 2 weeks. And then you see the temperature is 38.3 and the blood sugar is coming at 92. So what would be some, I'll leave that one there. What would be some differential diagnoses? Like what things could be causing that? Feel free to say in the chat or speak, up to you. It's okay, don't be scared, just have a guess. The 2-month-old who is vomiting and losing weight, and there's also a temperature as well.
Would it be sepsis?
Very good. Yeah, sepsis is a possibility. Very good. Yeah. Any other? Yeah.
I also think about pyloric stenosis.
Very good.
Or narrow with pylorus.
Very good. So those would be my top 2. Yeah, some kind of sepsis infective process you can see because the temperature is high and there's vomiting. And then pyloric stenosis. Why do you think pyloric stenosis? What things there would make you say that?
So the fact that the child is hungry, child always wants to eat water. Every time he takes food and tries to vomit the food, every time he takes the food and vomit, but so I believe there is some kind of of structural abnormality at at the level, maybe narrow pylorus.
Very good.
So that is not,
That's exactly right. So there may be even more than one thing going on. You're absolutely right. So a child at that age, especially sort of 6 weeks, really upwards to about 4 or 5 months, is the range for that. So you're absolutely right. So let's think about some next steps in managing and investigating this child. Let's say you're just seeing this child fresh in the ER. What would you do next?
You want to order for the CBC to see the white cell count.
I gotta have an IV line established, do follow the ABC method, make sure the patient airway is within the breathing circulation, have an IV line and make sure they check the hydration status. If the patient is dehydrated, we have to make sure the patient is hydrated. If the patient I'll do the glucose, RBS, and make sure that correct hypoglycemia. And then the soil say we'll do the lab, so do CBC to see if there is any infectious process.
Okay, you could do all those things, yeah.
Yeah, and then malaria spot.
That would be good, yeah. Anything else you want to test?
Yes.
Go on.
Yeah, so one important thing is that child needs to be resuscitated with IV fluids.
Okay.
Which is very important in patients with pyloric stenosis.
Okay, so tell me a bit more about resuscitating, like how much fluid are you thinking on there?
So resuscitating the patient with IV fluid is important. You do it cautiously, and the fluid of choice you want to go for is a saline, normal saline. You don't want to go with Ranger Lactis because one major thing is the patient can have electrolyte imbalance.
Oh, okay.
That's one thing that can happen with this patient, yes.
Sure. So yeah, there's some good thoughts there. I think one thing to bear in mind in this particular situation is the child is actually not too dehydrated. They're just always vomiting. So I would start fluid, but I would probably do maintenance fluid just to try to maintain the child, because if they're not dehydrated, then you don't need to put in huge volumes. So you'd probably do maintenance fluid, because you're right, if we don't, then the child will become dehydrated. So I would actually use DNS just to give a little bit of ongoing dextrose there. The other thing I would do, if I was suspecting pyloric stenosis, I would check some electrolytes. Can anyone tell me, like, here's some labs, like what are the obvious like problems in the lab test here? There's one that's a big red flag.
Malaria is 3+.
Yeah, that's an issue.
Sodium is 138.
Okay.
So sodium normal. I think it reaches up to 145.
Okay. Yep. So sodium is normal.
HB 6.4.
So a little bit low. So kind of moderate anemia.
Yes.
I'm seeing Roosevelt Matthews raising your hand. Do you want to say something?
Yeah, just to also add that potassium is low.
Very good. Yeah. Excellent.
Yeah.
So you're right in the 3+ malaria, but the main concern I have here is that the potassium is low. So we were talking on our diagnoses, and that's one of the things you will see in pyloric stenosis is you'll see a low potassium. So you see something called a hypokalemic alkalosis. So if we had the ability to do blood gases, you would also see like the pH would be actually going up as well. Like the blood would be turning alkaline. But the low potassium in itself, if you have a baby who's vomiting and you're suspecting pyloric stenosis, you do potassium, it's low, immediately in your mind, you're thinking, this could be pyloric stenosis. So let's just see. So just some lists of, I love to have lists of problems. If you have these complicated patients, it's good to have a list of issues. So you're right, Dr. Coker, severe malaria, hypokalemia, and this risk of dehydration because the child is not really tolerating the fluid. And then moderate anemia. So it's not at the level of transfusing, but we want to be monitoring that because it could go low. So my actions here, I would admit this child, obviously, maintenance fluid, treat the malaria, and then you would want to do you'd want to get the surgeons involved and do an ultrasound of the abdomen. So just to show you a little bit of a picture there really of some of the kind of anatomy of what's going on there. You can see the child there is just vomiting. You see the pylorus there in the stomach is very, very hypertrophied. It's big. So what happens is the food just is not passing all the way out. So you find the child just vomits, and they don't normally vomit greenish or blood or anything. They just vomit milk, and then they just don't gain weight. I think maybe 2 or 3 times I've been able to feel the olive. You call it like an olive palpation. That's a little mass there that you find in the epigastrium. So if you feel that, immediately you should be thinking, this could be a pyloric stenosis. So just to keep that in the back of your mind, the reason I wanted to share that case is it's an example of where you can have like 2 or 3 problems at the same time. So you can see the child is febrile. We know there's malaria. There's probably some sepsis going on. And then you've also got pyloric stenosis as well. So you're thinking on like 2 or 3 things at the same time. So I just want to give you another one. So this is an 8-month-old with a 2-month history of weight loss, a bit longer. They've come to the ER again, and the mother is telling you, the last 3 weeks, just always diarrhea and vomiting, and this child is just not drinking anything. And then you notice like there's a fast respiratory rate, SpO2 is 88, and you see the pulse is 178, weak and thready, CRT is 4 seconds, cold peripheries, reduced skin turgor, and the MUAC is 108. So can somebody tell me in like an ABC way, what problems does this child have?
Obviously,
Okay.
somebody talking.
Yep.
Go ahead. Go ahead.
Obviously, have problem with the airway,
Okay.
the breathing, and the circulation.
Very good. There's problems with
Yeah.
all 3 of ABC. Very good.
Yes.
Very good. So the breathing problem, you know, straight away you have high respiratory rate, low SpO2.
Yes.
And from a circulation, what does this child have? What's the medical
The
word?
pulse is really high, weak and shredded. The creatinine.
Creatinine. Oh, no, sorry, the CRT. Very refill time. Sorry.
Refill time.
I can. Very
Both
good.
peripherals and wildlife. So obviously it has circulatory problem.
Yeah. So that's shock. And the other thing, any problem with D?
Yeah.
Yeah.
I think the child also because of
malnourished.
vomiting and diarrhea, the child is also having acute, gastroenteritis as well.
Very good. So the child does have dehydration, and you can see, I mean, the child is not drinking fluids, and they have reduced skin turgor, and they've got diarrhea. So they've got 2 of the 4 signs of severe dehydration there. And what else does this child have that makes it even more complicated?
Sam.
Very good. Yeah. Now this makes things even more complicated. Actually less complicated, but it makes things more challenging with fluids. So can you tell me, like, what are we going to do? What are our like first steps of management here?
Yeah. So there is a whole management protocol for patients that are in shock.
Very good.
And who are also SAM patients. So I mean, it's a big thing. So if patient is in shock, first of all, we want to know if it is a SAM patient or not a SAM patient. Now, in this case, this is a SAM patient.
Very good.
So what I want to know, in management protocol for the patient, we want to know is the HbA as well.
Okay.
But HbA, I think HbA was 6.4.
Let's
I
say
don't know
6.5. We say 6.4.
Okay. Yeah. So managing this patient in shock, we want to give a winker-lytics if all the HbA is above 6 grams. We want to get the patient out of shock. So give winker-lytics with dextrose 5%.
Okay.
We give 10 mils per kg over 1 hour.
Wonderful. Good.
Yeah.
Okay.
that-
And then when
Okay, and
you,
then
yeah, go on.
yeah. So if we can get a patient out of shock, maybe we especially this patient having diarrhea.
Mm.
If the patient can tolerate after the shock, maybe we'll have some pauses, peripheral pauses, patient, because in SEM to really diagnose severe dehydration, you don't really let it say that this patient is severely dehydrated in SEM patient. Well, for sure you can know that it's a shock. So we get the first dose of regular 10 ml per kg for the first 1 hour, and then patient out of shock, then we can do what we call the maintenance fluid of Resomar.
Very good. So
Resomar
you
will give
use
5
Resomar.
ml per kg over 30 minutes for the first 2 hours, and then
Mhm.
the next step will be 5 to 10 ml per kg or every hour for the next 4 to 10 hours.
Very good.
And then if you can start tolerating feeding, we start with F75 based on the weight.
Beautiful. Yeah, that's really good on the fluid. So you're right, the DRL or the DNS. So as long as you have 5% of dextrose, that is also with some saline or organolactate, so it's isotonic. Remember, you're just doing your one-time bolus. You're absolutely right. So 10 mils per kg, and then you're moving to Resomar. Now, I would, child like this, I would immediately insert an NG, because if I'm hearing the child is vomiting all the time, even if you give them Resomar orally, sometimes you'll see the ward is busy, the patient's in the ER, everyone's running around, and you'll see sometimes if we're just giving the mother some Resomar and say, try to drink, the child will just be vomiting everywhere. So that's why this situation, I would use an NG tube. So you're absolutely right though. First things first, any other things you could do? So you talked about the fluids. What else would we do here as well as fluids and feeding?
O2 therapy.
Very good. Yeah. Simple things first. O2 therapy. Very good. So there we are. So other thing to do is hemoglobin as well. We talked on that very, very briefly. Now, it's very frustrating. You know, we used to have these HemoQ machines. So you could do a hemoglobin. It would take like, you know, if you have a HemoQ, it takes like 5 seconds. So we're still waiting for those machines to, yeah, I'm going to get them. When I come back, we're going to have those. And then you're right, the dehydration and the nutritional support. So you gave a very good description of the Resomar, so I'm not going to go through that again. The only thing I would say is remember to check your RBS, because malnourished children, they're highly at risk of hypoglycemia. And we all know how to do that. That would be your, if you're going to treat that, it's your D10, 5 mils per kg. So other things to do as well. You can think about electrolytes as well. That is perfectly fine. I would probably want to do some electrolytes. Make sure child is staying warm. You know, you don't want to put them next to the window or something like that. And then start some broad spectrum antibiotics. Now, normally they start with Ampingent, but you can, if you're suspecting meningitis or you think the child is in a coma or really severe, you can move straight to ceftriaxone. That's perfectly okay. So all those things are very good. Yeah, good. So I think we've got that one. The most important thing is just to remember, if they're malnourished, then we have to really be monitoring the fluids. So even while you're giving your DNS or your DRL, I would ask the nurse to be checking the SpO2 every 15 minutes, because we want to make sure we're not overloading the child too much. So very good. So number 3, this is a slightly more complicated one. We have a 1-year-old coming to, this time you're in under 5s, and they come with worsening dyspnea. And the mum keeps coming. You look at her child, and the child's been coming again and again with chest infections. And you see the last like 4 or 5 weeks, there's been weight loss and fever. And the mum complains every time the child is trying to suck, the child is not able, becomes too breathless and just doesn't suck. And then you see the SpO2 is 86. And when the child is lying flat, they're getting more distressed. And you can hear like crackles all the way, like both sides of the chest. You see pulse 153, cold hands, and CRT is 1 second. So there are many possible answers here. Can you tell me like what are some differential diagnoses here? Like what things could be going on?
Pulmonary TB.
Okay, very good. Pulmonary TB.
Pleural effusion.
Good. Yeah, I hadn't thought of that. Good. That's a good point. TB and effusion. Tell me, why are you thinking TB? What things are in your mind?
Because long history of recurrent chest infection, dizziness, fever, weight loss history.
Yeah, very good. Those are all good things. Weight loss, worsening dyspnea. Yep, someone's telling you they've had lots of chest infections, they had amoxicillin maybe 20 times, no improvement, blah, blah, blah. That's a really good thing. Okay, any other possible diagnosis?
I'll also consider severe pneumonia in this case, yeah.
Yeah.
Even though, I'll consider severe pneumonia.
Very good. I would definitely consider severe pneumonia. Yeah. And there's maybe one other group of things you could consider. There's like two little clues in here that might tell you.
RSS.
Okay, good. It's not the one I was thinking on, but it's a good possibility. Any child who's losing weight, you think on ISS. Very good. Yeah. Beautiful. And one other thing. I'm really pushing hard.
I can also think about empyema.
Oh, okay. Yeah, you could. So the other thing would be in my mind would be a cardiac thing. The reason I say that is two things really. One, if someone is complaining the breastfeeding is always being interrupted, and the other thing is when the child is more distressed when they are lying flat. So it's just good to keep that in your mind. So this is an interesting case because it's not a simple, oh, here is a chest infection, blah, blah, blah. There's a lot of different possibilities. So this is one where you think about your problem list. So we talked, I mean, hypoxia, we know that is there already. And then impaired circulation. So this is where like you have one or two signs of shock, like the hands are cold and pulse is fast, but CRT is okay. So you think, okay, the circulation is impaired, but it's not shock. Then we know there's some kind of febrile illness, whether it's pneumonia, TB, something is going on. And the weight loss is also an issue. So how would we, like, what would we do for this child?
Yeah, so again, we can do our ABCs, make sure the child airway is cleared, put on oxygen if the SpO2 is low. We establish our RV lines. We check for vital status, hydration status. If child is dehydrated, we make sure we give some fluids, out of maintenance fluid or so. Check the RBS, our infectious causes, CBC, malaria, spot. We'll also do the chest X-ray, do echocardiogram.
Okay. Yeah, good. So agree with most of those things. So you're right. You would want to, initial management, you get your oxygen going and you'd start some antibiotics. I put why there, but we already know why. Echocardiography would be very good in this situation because we are thinking like, is there a possible cardiac thing going on here? And that's how we diagnose it. So very, very good. And nutritional support. Yes. I mean, this child, you can see the mum is telling you they're losing weight. We haven't given you any MOAC or anything, but you would need to be checking the Z score and all of those things. And then you're thinking about your TB would be a diagnosis. So you want to do a chest X-ray as well. And then once you confirm your cardiac thing, you need to think about diuresis and where we're going. Now, cardiac children, very, very hard because a lot of the time they need surgeries, and to get hold of that is very hard. But it's good to be aware of the investigations we're doing to think in that way. So just giving you two X-rays there. Can anyone tell me, like, the first X-ray on your left, what can you see there?
The first X-ray looks more like increased air, mostly more like a pneumothorax, with some opacities in the right upper lobe.
Okay.
Well, see more, it's more like increase of air, pointing the motor pneumothorax. And the second one shows cardiomegaly.
Okay, good. So the second one, you're correct. There's definitely cardiomegaly going on there. So that would tell me there's some kind of congenital heart condition, whether that's a tetralogy of Fallot or something. You would need to do an echo to be sure, but you can see definitely some kind of cardiac something. And this other one here, this is actually a cavitation in the right upper lobe. So this, if you see that, straight away, I'm thinking TB. Yeah, because you can see, I mean, it's not really so much a pneumothorax, but you can see the all the sort of lung parenchyma there. There's all that kind of whitish area that's there. And then in the middle of that, you can see like almost like a little circle. And that basically is a cavitating TB lesion. Now, if you see that, that means your patient has had TB for quite some time. Like it's already gone through the infective stage and now it's starting to cavitate. So that's quite a serious thing. You may be right. There may be a small pneumothorax at the apex there. It's hard to tell, but that's definitely a cavitation. So the reason I put those there is just to sort of show there can sometimes be a little bit of diagnostic uncertainty, but you can certainly see the two different pictures there. So a child like this, you see they're getting malnourished, they're getting, they're getting sicker every day. They're not improving. I would start some investigations as you've discussed. So that would be really good. So I want you to imagine, we're saying OPD, we say under 5, it's the same thing. There's like the mum says, oh, the child was convulsing like 48 hours ago. And now you see the child is very pale and looking kind of sick. And then while you're having your consultation, you see the child has another seizure. So what are we going to do for this child? Imagine you're just sitting in under 5 and everybody's just running around, not really doing anything.
Yeah, so again, with this sort of seizures and presenting with pallor, I mean, that's anemia, and then having no episode of seizure. Always I want to do, I will start with the ABC, securing the airway, breathing, interpolation. So what I want to do here, first of all, is to arrest the seizure. After I sort of IV lines, arrest the seizure, and then it can correct that and it can get a lab HB to start transfusion. First of all, also before transfusion, to make sure that the AT patient is the same but not the same patient.
Very good. All those things are very good.
Yeah. So based on the classification of same or non-same, I want to transfuse them better.
Okay.
And then to follow other labs. Yeah.
Sure. So those are good things. So let's imagine your labs, they come back and the glucose is 39 and you see child is not in shock. And these are just your emergency, like point of care labs, because, we're just an emergency. So the lab is kind of taking time. So we've just done these ones as an emergency. What's the immediate thing that we need to treat out of those labs? Like what's the thing which will make the child's expire if we don't do immediate action?
Glucose.
Very good. Excellent. Very good. Okay, good. The reason I put this in is you have ABC, then you have DEFG. Don't ever forget glucose. Okay, so it's the most, a child who is seizing, most important lab test, and you get a result in like 2 seconds. So, so what I would do, you're right, all these things are good. So we want to treat all these things. Now the hypoglycemia, we know we're going to give our D10 5 mils per kg, or if you have a child who's seizing, just take a guess, have an estimate as to the weights, because you don't want to be putting them on the weighing scales and blah blah blah. You want to take a guess. And then with the anemia, so 5.5, if the child's not in shock, I would just be monitoring that for now. I'd be wanting to check it at least every day. If it goes below 5, then you want to get a transfusion going, but there's no rush. And then the important thing is to think about your causes. So if I told you that the child, let's say the child had neck stiffness and photophobia, and then they started seizing, what's happening there?
Meningitis.
Very good. What if I told you the child had been like kind of talking in a strange way and very confused for like a week, and then started to say some strange things, like they were seeing things, and then they started having like a bit of a seizure, and then they were kind of okay, and then they started going down again and started having seizures, and like their eyes are just always twitching, and they were just kind of confused even when they were not having a seizure? Do you know what that could be?
Cerebral malaria.
Could be, yep, cerebral malaria, very good. That's one of the two things.
I'm thinking about seizure disorder.
It's possible.
Like epilepsy.
Okay. If it just came on acutely and they had like a fever as well.
Yes, occupying lesion.
Okay, that's a possibility.
Normally for seizure in children, because of age, I think there are three things that I look at. One of them, like you talk about infection, so the meningitis. In this case, it's not likely. Malaria could be a possibility. Although electrolytes, like maybe hypoglycemia could be another thing. That's one that can cause seizure. And the hypoglycemia itself can cause seizure as well in children. But we have already treated the hypoglycemia. The way from the story giving is intermittent and is associated with more or less fluctuating level of consciousness. So so the infection will have also all the things that are infection, electrolyte imbalance, and malaria, which include malaria, meningitis, and
Sure.
I think we are exhausted a few of the differential about how to keep a differential water. Yeah, like you're saying.
Yeah.
But there are 3 or 4 things in children that cause over seizure. Yeah.
Yeah.
Most common.
Yeah, those are all absolutely right. The other thing in my mind would be an encephalitis. So if you have a child who, like, they're sort of like, if there's a history of confusion, altered conscious state, it's taking almost a kind of subacute course, then I'd be thinking on encephalitis as well. So yeah, those are all good thoughts. Good. So what's happened? There we are. So just wanted to share again. I mean, you know this protocol already.
Yeah. So
Yeah.
Yeah, the encephalitis aspect, I just wanted to, I'm concerned a little bit about, because most of the time we understand that patient who has encephalitis, who's basically infection of the brain, so they will have issues with changing that mental status compared to patients who have maybe meningitis.
Sure.
They may be a little bit alert. So there's a component of meningoencephalitis. I don't know, this is kind of picture or just something that is classic with for fluctuating level of consciousness or seizure that maybe we're thinking more encephalitis. I just thinking that because meningitis, having seizure because of inflammation, and that affects the brain function because of changing the level of consciousness. I think I was thinking, as part of when you talk about encephalitis, I also talk about meningoencephalitis thing. Many options are basically the same, and whether you are looking at bacterial or viral causes,
So that's a very good point. So yes, I mean, you can have some overlap between meningitis and encephalitis. If you want to be 100% sure one way or the other, you would need to do a lumbar puncture. Now, just to give you a bit of a sort of clinical thing, now encephalitis is more likely, I mean, the kind of more common cause of it is HSV, so herpes simplex virus. That's normally what does it. And that usually will give you almost a kind of subacute sort of course. And you'll have a child who's been unwell for some time, and then they just gradually sort of get worse and worse. Then they start having seizures, altered personalities, all of those things. But in practice, what I would do if this was an emergency and I was suspecting both of those, I would definitely start some high dose ceftriaxone, or I mean, chloramphenicol is another option if they've already had ceftriaxone, just to cover the meningitis side. And if I was thinking about encephalitis, if it was in my mind and there was a bit of a history of suspicious, or there were, particularly if there's focal seizures, like if a child has, particularly if it's just a hand that's seizing, or if it's just some eye movements, that would also move me more towards encephalitis, because it'd be a particular part of the cerebrum that's affected. And so if I was thinking on that, ideally you would want to start some acyclovir or valacyclovir. Now, getting hold of that IV is not easy, but it is possible. So that's what I want to do. And the other thing you need to do if you suspect encephalitis is start high dose steroids as well. So either dexamethasone or hydrocortisone would be helpful, just in terms of reducing that kind of brain inflammation and edema. So encephalitis is rare. Normally there's a bit of a history of kind of subacute symptoms. Things have been going on for a while. And it's more common in a child who has ISS or if they have some other ongoing condition. So those are the times to think about it, but it's good to think on. I'm seeing Dr. Cameron, I'm seeing your hand is raised as well.
Yes, I have a question,
Yeah,
concern with the HB of 5.5. So, I don't know, as we practice, there are changes that have been made, to the medical setting. Now, I remember way back in MSF, HB less than 6, especially with if I want to less than 6, and we usually get we to transfuse. But again, sometimes HB less than 6, maybe 5.5, 5.8, 5.9, without decompensation, we want to observe. So I want to know also in this case, with the HB of 5.5, without this decompensation, what if they are decompensated, will you want to transfuse them or not?
Yeah, so if the child, you're right, if the child was decompensating, so essentially if they're going into shock, or if you're seeing that they're becoming very breathless, and you think the breathlessness is because of the anemia, then yes, I would transfuse. But if it was a child who had no signs of shock, they're not breathless, there's nothing to suggest decompensating, and it's just that they've gone into, they've just had a seizure, then I wouldn't be rushing to do it. So there's kind of between 5 and 6 is like your contentious area. So you want to be monitoring it because it can easily go down, especially if you have a high parasite count or something. So you want to be monitoring it. And anything less than 5, then yeah, straight away I would transfuse. But you're right. So if the situation had been a little different here, so if let me just find, if for example the history was the child had pallor, and then you see the hands are very cold and the pulse is 200 and the CRT is like 5 seconds and the HB is 5.5, then yeah, you're right, they'd be decompensating, so you want to transfuse them. So yeah, but there is a little bit of contention between 5 and 6. It's a little bit of a gray area. Nobody is going to get like angry at you if you transfuse them. It's not a disaster. What would be a problem is if you have like a child with HB 7 or 8 and someone is just like panicking and transfusing. But 5 to 6 is the kind of contentious area where you want to be monitoring, and sometimes you can go clinically a bit as well. So I mean, we all know, we're human beings, we know the situation. So like we know that if we get HB from the lab, it's not always accurate. And sometimes, I mean, we have the HemoQ machines. If you use the machines, they are very accurate. The actual HemoQ machines, they're really good. But if one of those is not available and you're relying on the lab, we're all human beings. Sometimes we can, if it says like 10.5 and you look at the child and you think, my goodness, the child is very pale, and you can say, okay, we'll do this clinically. So it's not too much of a, don't be stressing too much on that. So yeah, good questions though. So yeah, just to say our protocol, and I think we've done this before, I'm just going to go through it again. So if you've got a convulsion longer than 5 minutes, you're doing your diazepam, you wait 10 minutes. If things don't settle, you can do diazepam again. If still no better, then you move to phenobarb. And the important thing with your phenobarb, you have to be aware, like some of the staff will know how to give it. Some of them will be a little bit confused. So what you don't want to do is just put the phenobarb into NS and then just drip it slowly, because it won't work. So you have to take your time, do like 15 mg per kg and slow infusion over 15 minutes. Otherwise you can get a lot of challenges and problems. So just to be aware of that. Good. So good, we're moving well. This is a slightly different. Yeah, feel free.
No, it being emphasized what you said, but it's okay. I think with the people will not be rushing to transfusion.
Yeah. So this situation,
at least less 5 or less for malnourished. Yeah. No.
Very good. So I would not be rushing to transfuse. I would be doing HB like every day, or even in the afternoon. I would say, let's come back to that child in the afternoon or evening time, repeat the HB, see where things are.
Yeah. The other thing as in this case, clearly the child will not need transfusion. I'm thinking that the child is 5.5 with number of days, and pure or severely anemia, then you can use your clinical judgment. But in instance, you need to maybe supplement with, because this is like moderate anemia, you need to supplement with they better talk on the ferrous or supplementation with this syrup.
Sure. Yeah. Now you can
Emil, I think look at that.
Yeah, you're right. You can start ferrous. The only problem, you have to be a little careful with the ferrous, just because it can make children vomit. So I would normally wait until the child is really stable, and then I would start the ferrous after that. But it's a good thought. And the other thing is maybe start some folate as well. So, the two of them together when the child is more stable, and then all your other things, deworming them, those kind of things as well. So great. Good. So last example, slightly different. We got like a 3-year-old again coming. The mom is saying the child has got a delay in learning to speak. You notice there are some strange like facial features. And the mother's also telling you that the child becomes more breathless when they're running around. And when you examine, you notice this kind of low set ears, a single palmar crease, and you see reduced head control. So what do you think could be going on here?
Down syndrome.
Very good.
I think this child has a congenital condition that affected the heart, and maybe multi systems, also musculars can be delay or so.
Very good.
It's kind of something on birth.
Yeah, very good. So you're right. I mean, it's almost certainly this is going to be trisomy 21. And we see, it's interesting, we seem to see a lot of it there at ELWA. I don't know why, but we see a lot of children with trisomy 21 coming. My second question, you kind of half answered it there, Dr. Gono, but what other conditions can you get with trisomy 21?
Yeah, so that about it, as you speak right now, we got one right now on the beach wall.
Oh, very good.
Yeah, we did yesterday, Dr. Koa and I, we did the echo, we sent the echo for interpretation. Today we order for the x-ray. Of course, so like you're saying, children with trisomy 21, they come with other, abnormalities that we can come with cardiac disease, they can, GI problems, musculoskeletal problems, so it's kind of like, they are affected. Even CNS problem, it comes with CNS problem as well, seizures and stuff like that. So, so people we diagnose or we suspect Down syndrome, which we do proper examination. They can even have like they can come with GI problem like stenosis or whatever stuff. Yeah. So I think they need a thorough examination to rule out all organs that all parts systems have been affected. Yeah.
Yeah, that's very true. So that was my main point, is that if you think of any organ system, pretty much all of them can be affected by trisomy 21. You're absolutely right. So
So
go on.
My only point here, especially with the trisomy, because I think what I know.
Oh. Yeah, you're saying over diagnosing? Oh, I lost you there. That's okay. I think we just may have lost Dr. Gono, but it's okay. I mean, it is a concern. Sort of, it's very easy to overdiagnose. You're right, with trisomy 21, because the reality is there are so many other congenital things that you can find, and sometimes they can all kind of get mixed up. Yeah, so it's just important to, ideally you would do genetic testing, but that's not easy to access. So it's just important to think about, are we seeing enough of these features? But the important thing is just to be aware of the other conditions. So there are so many other things that can happen if someone has trisomy 21. So, I mean, there's long-term things like the increased risk of leukemia. Older patients get dementia, there's heart murmurs. So the important thing, as Dr. Connor said, I think Dr. Kamino, you saying, sorry, doing an echocardiogram is a really good idea, because so often they will get these cardiac conditions. Like the most common one is the atrioventricular septal defect, like both of them basically atrium and ventricles involved in the defect. And that is very hard to treat. That needs usually 2 to 3 surgeries. So it's really important just to be listening out for murmurs. And then other ongoing things. I mean, duodenal atresia, you get that from birth, and that is, I mean, we talked about pyloric stenosis, but the duodenum, it's further down. You're more likely to sometimes get biliary vomiting. The child will usually be really wasted and malnourished. And then less serious things like sleep apnea, we're not too concerned about that. But the bigger two things really are your heart and the bowels. But so just to be aware of all those things. So I just wanted to show you a little diagram. I know we're slightly going off topic, but I just thought I'd put this in because we're seeing so many of these children. And if you see a child, you can see the sort of characteristic facial features there. And there, there are these things that you're supposed to look for, brush field spots on the iris. You don't always see those, but it's just good to be aware. The easiest way to really look for Downs is normally I'll start by looking at the child's hand, and I'll look at the palmar crease, and I'll look at the usually the 4th and the 5th digits, and you can see there's clinodactyly. So the 5th finger, the pinky, is a lot smaller than it would be in you or I, sort of relative to the rest of the hand. And the reason I put this in, I mean, these children, they are prone to cardiac conditions, but they're also prone to even simpler things, like they're higher risk for aspiration pneumonia. They're higher risk for even just simple kind of gastric infections. And we had, there's one child there, must be almost a year ago now, who came in really in extremis, like the SpO2 was like 69, 70, and the child was just in complete heart failure. And we had to put on CPAP to basically do some pressure to actually get things back to normal. So yeah, so that was just to be aware that if you see a child who's coming with trisomy 21, it's good, as you've done, just to think about all the other possible conditions that are kind of associated with that as well. And then other things, I mean, you can see the tongue there sometimes looks a bit different, the widened gaps between toes. So just all kinds of things that it's good to look out for, really. So my main kind of take-home message is kind of practice and teamwork. And so the important thing is just to keep kind of putting all these things into practice, keeping going. Very good. Yeah, Dr. Go, I'm just seeing your comment in the chat. Consider a list of other chromosomal disorders. So what I'd like to do, if it's okay with you guys, my next week talk, I will do something just specifically on congenital conditions, where we'll look at some of these other ones as well, like, trisomy 13, trisomy 18, because you're right. So often we're just thinking, oh, they look a bit strange, it must be trisomy 21. So you're absolutely right. So next week we'll have a talk on, let me write that in my diary so I don't forget that. We'll do that next week. Excellent. And any more questions or big issues going on right now?
Yeah, Dr. Maki. So why are you trying to write your diary? I want to know something. We also have a case. Yesterday we had a case presentation, a bedside presentation on seizure disorders. We were specifically looking at absent seizure. Okay. So we checked the management protocol, and then we found that it was valproic acid, but then valproic acid is not safe. Safety is not there, in children less than 2 years old. So I want to know if you have 11 or 12 let's say 11-month-old baby with you diagnose and you're suspecting absent seizure. How will you manage that in our setting here?
Sure. So you're talking about like it's an epilepsy kind of disorder where they're having recurrent seizures.
Staring. Yeah, repeated seizure, staring, less than 2 to 3 seconds, you know.
So that situation, the first line would be carbamazepine. That's your first line in a child. And the other one you could use if that's not available is Keppra, so levetiracetam. But the better one for that would be carbamazepine. So you're right in that valproate is not too good in smaller children.
Okay.
Let me undo the share. Stop share. What happens if I do that? There we are. Good. Yeah, but it's good to have that question.
Another thing, another question, please. Probably I may check, but you may also want to help me or help us as a team. The clear classification of anemia in neonates or in infants, that's in children. I mean, when do you consider this as severe anemia, moderate anemia, mild anemia, you know, stuff like that? I mean, I know you're doing that in adults, but for infants or for neonates or children, I don't know the clear cut. When do you consider as severe anemia that you want to transfuse?
Very good. So, good question about transfusions and anemia in children. Yeah, so really, I would say any child who's got a hemoglobin less than 5 needs to have a transfusion. Because physiologically, even if they are compensating, they're going to be suffering. They're going to be having problems. So that's what I'd say is severe anemia, anything less than 5. And then also any child less than 6, if there are signs of shock, if there are signs of like severe breathlessness, or if they're a sickle cell patient. The reason we say a sickle cell patient is because their hemoglobin can drop very quickly if they're suffering from sickle cell. So if that happens, then you need to transfuse. So that's what I'd say is severe anemia. The moderate and mild is kind of more of a gray area, really. I mean, it varies setting on setting because a lot of children in that setting will be compensating very well. So I would say any child with hemoglobin like 6 to maybe 8 or 9, I would refer to that as moderate anemia. And then really anything above that would be either mild anemia or no anemia. But the important thing would be the transfusion. So good question though. Question about
Dr. Mikey, what if the child conjunctiva is spilled?
Well, ideally we need to know our hemoglobins. Like if you have a way of getting an accurate hemoglobin, like if you can use the HemaQ machine, or if the lab is being accurate, then I would use the lab. But if you are just thinking, oh my goodness, they're very pale, and I'm concerned that our lab tests are
respiratory distress.
Yeah. Okay. So if they're very pale, severe respiratory distress, and no way to get a hemoglobin, I would transfuse if I was that concerned. Can I ask a question? Do we have like the HemaQ machines? Are they available right now? Like, is there one in the ER?
I don't think so.
Oh, okay. I'll bring some.
We're not using them. We're not available right now. So the other issue, like you said, in anemia is a little bit different when it comes to the kind of, especially with nutritional status. So yeah, so we will look at the other things. Even though if you have anemia that is significant with respiratory distress, and you think that the respiratory distress and have no other cause other than the blood level, then you will want to treat like that. But if someone has respiratory distress, maybe due to maybe other respiratory tract infection, with five.
Sure. Yeah. So let's say they have like severe pneumonia, you're hearing crackles on one side, and HB is like 5.9. I would say that you probably don't need to unless there is shock, because it's more likely that the pneumonia is causing that. Good point. Just seeing your point about chromosomal testing in the future, I would love us to do that. I think it'd be great. It will take some organizing. It's one of those things. I think it's wonderful. How to put it in place will take time, but I think it's a wonderful idea. So I appreciate the idea. I'm just thinking it will take some time. But yeah, I will try to get some, we did have HemaQ machines. So I want to find out what's happening with those because it's the point of care labs, the glucose, the HemaQ, RDTs, those things should just be boom, boom, boom every time. We should be able to do those. So we'll get that sorted. At least when I come in 6 weeks, we'll have that. Any more questions? Okay, I think I should let you carry on. Oh, hang on. Could you send me a slide from? Yes, yes, I will send some slides over to Maria as soon as we come out. Yeah, excellent. Okay, thank you very much.
Okay, thank you, Dr. Mikey.